morning, everybody, and thank you so much to the organizers for this opportunity to be able to stand here and say a few words. I don't claim to have all the answers, but I do claim that today I'm going to challenge you a little bit, just to think a little bit deeper. I want to apologize in advance for my voice. I've just come back from a conference in Denmark where I had the bad flu, and as I was sitting there, my chest started to give me problems, and I was so glad that we first had the entertainment so that my chest could just settle. But I'm sure that I'll get through this presentation this morning. I was very encouraged by the opening remarks of the conference convener and that one quote that was said, "To change the world, start with one step. However small, the first step is the hardest of all." I think that is very powerful for us where we are going in terms of disability and rehabilitation. I was telling my team this morning when we sat at breakfast that many years ago when I started in this field of disability and rehabilitation, there was a hype around disability and rehabilitation, and everybody was talking about it, and suddenly there was a quietness because something else took over. And this morning in the opening talks, we heard that we need to start advocating again for disability and rehabilitation. And as I'm talking this morning about telerehabilitation, we all know that the fourth industrial revolution is on our doorstep. It's there, it's happening. AI is all over. And the question I want to ask, is this something that we can introduce in terms of mental health and disability inclusion? So this morning, my topic is about, is telerehabilitation a scalable solution for mental health and disability inclusion? I say once again that I don't claim to have all the answers because every context is different. For those of you who don't know, I come from the University of the Western Cape, South Africa, and that's not UCT, not University of Cape Town, it's University of the Western Cape in Cape Town. That's right at the foot of Africa. And our context is totally different in the spaces in which we operate. And even when I said now I don't come from UCT, I come from UWC, even in that, in the same region, our context is different. And therefore, when we talk about is telerehabilitation a scalable solution for mental health, it will be context specific as we talk about it. And so I want to do telerehab, but my technology is not helping me this morning. Okay, thank you. You see? So just to give you some context about where I come from and why I can speak about the topic that we are talking here, I have been not a psychotherapist, I'm a physiotherapist in my previous life, many years ago. I graduated as a physiotherapist and I continue to do work in the area of physiotherapy. And so in supervising students, we have been trying to understand what is the distance that we're needing to bridge in terms of what we're needing to do. And many of the studies that we've conducted is that there's a transportation barrier that continues to hamper access for people with disabilities to various sectors, whether it's the higher education sector or even health. There still continues to be a service access gap. And so we have done studies around experiences of people with disabilities accessing rehabilitation services. And then there's the health disparities in terms of rehabilitation models for marginalized disability groups. And what does this mean and what does it look like in the space in which we're wanting to operate? I've also continued to do work around designing then telerehab research and telerehab programs for type 2 diabetes patients. And in South Africa, in the context in South Africa, we have access to rural areas as well as urban areas. And the needs in urban areas is different to the needs in rural areas. And so we have been doing, trying to understand whether clients in the rural areas such as Limpopo province in South Africa want to have access to telerehab programs. That is not top of priority for them. That is not what they're wanting to do. That is what we as health professionals want to do, but that is not top of priority for them. And so understanding who the end goal users are has become important for us. We're also busy with a big project around the role of community health workers as it relates to implementation of telerehabilitation. And so when I said earlier on the service gaps, we in South Africa have introduced community health workers to help our health professionals in the hospital setting to be able to access clients in the communities to receive services. And so we are trying to find out, are community health workers ready for this telerehabilitation that we are talking about? Or is this just something that we would like to impose on the end users rather than understanding where all stakeholders are coming from? So in understanding all of that, we also need to understand when we're talking about people with disabilities that it's not only the person themselves, but there's the support system around them that also needs to be looked at. And so we are talking about developing guidelines for parents with children with development disabilities using a capability approach. So these are all research that we have been doing to bring us to this point of talking about telerehabilitation. We've done physical activity and sport inclusion for disabled children in Kenya research, and we've also done support services for persons with disabilities across Kenya. Why am I giving you this background? We need to understand that it's taken us years. This is the 10th Disability and Rehabilitation Conference. 10. It's taken us years. This work has taken me years, over 20 years, to get to this point, and we're still not getting it right. And so these kind of conferences are so important for us to continue the conversations and to continue creating awareness and continue advocating for people with disabilities. And therefore, I thought, let me bring this in from this point. Finally, as I want to talk about telerehab, I cannot talk about the fact that I don't do research in the area of digital health solutions. We are doing research in terms of training health professions, educators, our students, and how can we use virtual reality research to be able to bring all of this into what we are doing. I've also published a book on self-management programs. Why is that important? Because when we're wanting to talk about telerehab, we need to understand that the end user is able to self-manage whatever condition it is that they are having. And then we need everybody to be able to play a role in where we are wanting to move. So this has become important in the years of work and as we are transgressing to where we are getting to in terms of 4IR in health systems. So what have I done today? We've been able to identify the problem in terms of distance barriers, service inequities, family support gaps, as well as community isolation. And we're wanting to move to a solution. And the solution we are thinking is around telerehabilitation. So do they have then digital connectivity? Is there remote access that we can give them? What is technology-mediated care? And can there be virtual inclusion platforms? So this is what we are starting to think as we are starting to bridge the gap between the problem and the solution in terms of where we are moving and what we are wanting to achieve. So today's presentation, I've did a whole talk and I haven't even started the presentation yet, but today's journey together, I want to just take you through the reality, the statistics that still continues to exist around people with disability, how telerehab works in practice, and then thinking about a rights-based approach for ethical implementation and not just for the fact of implementing for the sake of implementing, and then your role in making this vision a reality. So the human reality is that over 80% of people with disabilities live in low and middle income countries, and many of them have little to no access to mental health services. For some, mental health care is hours away, and for others, it's totally out of reach. And millions of people with disabilities in undeserved regions face significant barriers to care. This is still our story today. The research I spoke about earlier on was done many years ago, but today we're still facing these challenges in our context. So I want to start with a question. What if the biggest barrier to mental health care isn't funding or facilities, but simply distance? And what if technology could eliminate that barrier entirely? Do you think that's possible? How many in the room think that's possible? Not many. I have to convince you this morning. Not many think that's possible. But yet we are operating in a space where everybody is advocating for the fourth industrial revolution. Everybody is advocating for technology. Everybody is advocating for AI, for VR, for AR. But yet, even this morning as I speak to you, we're hesitant to put up our hands to say that perhaps this is a solution in how we can solve this problem. So let me get you thinking and ask you maybe what it is that we would like to do. The growing burden of mental health challenges among people with disabilities is real. It's not something that we're making up, because even in the post-COVID era, we know that this has increased, and not only for people with disabilities, it's increased for everybody. But this is particularly relevant in undeserved and rural areas, and there's a need for innovative, inclusive solutions. And maybe, just maybe, telerehabilitation can be the game changer. So what is this telerehab that I'm talking about? It's the remote delivery of rehabilitation services via digital technologies. That's a very basic definition. It could include various ways of doing it, like video consultations, mobile apps, your phone, online support groups, etc. The one big benefit that all literature talks about is about the improvement of access. And that was one of my biggest challenges that I mentioned at the beginning. And it can ensure continuity of care, and it can provide the psychosocial support that is lacking in current instances in terms of service delivery. So why does it matter now? Why do we need to talk about it now? During COVID, when the whole world was hit with COVID, we needed to find alternative solutions. And then there was acceptance of remote care models. Before, people said this was unethical. Remember? If you do remember, if you were one of the first-line health practitioners, you would understand this conversation. So post-COVID, acceptance of remote care models became important. There was a rapid digital adoption and mobile penetration all over, and there was this global push for inclusive, scalable health solutions. There's various documents that speaks to this in terms of where we are needing to go. But the challenge was always, what is the context in which we would want to do this? Is this applicable in every context in which we are operating? These are just some of the quotes that I'm going to share with you from some people across rural participants that we've met, and their stories and the experiences that taught us about telerehabilitation. That in actual fact, it's not just about technology, but it's about dignity, it's about choice, and it's actually about human connection, more than what we might have been thinking about it. So one of the people says, the peer support groups online connected me with other disabled people for the first time. I learned I wasn't broken. The system was. That tells us a lot about what's happening in the system and not necessarily in the lives of the person. Another one was, before telerehab, I had to choose between my therapy appointment and my job. Now I can attend sessions during my lunch break and stay employed while getting the support I need. which means they have access to care and they can continue working. And then there was another person who said, having my mental health support accessible from home means I can manage my anxiety about public spaces while still getting help. It's given me back control over my healing journey. These are the voices of people who've been exposed to telerehabilitation. So this case study that I want to present this morning, just to show you that it cannot just be health professionals who thinks about this, solving this problem in this way. We had weekly therapy sessions via mobile app. We tried to reduce the travel burden and increase session attendance via online. And we wanted to improve mental health outcomes and quality of life of the participants that we spoke about. But the solution required an interdisciplinary approach. It needed us to project focusing, creating access to affordable data while this was a health project. Because in the rural areas, access is the challenge. Access to healthcare, but also access to data. Access to mobile devices. That was a challenge. And what we had to do is we had to take a step back as health professionals and say, how do we address the need of the communities rather than just forcing this telerehab project down their throats in terms of what we're wanting to do. We then could connect as a university, connect to another project who was operating through the Information and Communication Systems Department around taking data, making data affordable in rural areas and creating networks in people's homes so that they could have access to data. And those became central places for people to be able to meet to do what they are needing to do. So suddenly, it was not just about health professionals, but also looking at the technology component and bringing in others to be able to find a solution that would work for more people. When we talk about collaboration, it's talking about multidisciplinary teams across regions, but also across disciplines in terms of what it is that we are wanting to do, and not just focusing within the health sector. And so we needed to understand that when we start to talk about finding solutions for everybody, there needs to be co-creation. And in the co-creation of the solutions, we needed to include, as you saw, we included the participants' voices as well as other sectors to be able to assist us in driving what we wanted to drive. Through a health project, we were able to improve economic barriers as there was job creation through the process in terms of what we're doing, an unintended outcome of what it is that we are wanting to achieve. So everything I share today is grounded on one principle that guides my research. Disabled people are the experts in their own lives. People with disabilities are the experts in their own lives. This isn't about technology for disabled people, it's about technology with. We need to create with. So we're needing to understand what are the views of those who live the experiences that we're talking about. So when we talk about telerehabilitation through a rights-based lens, we need to talk about nothing about us without us. We need to move from a medical model to a social model. We need to understand self-determination, and there needs to be equal participation. It cannot be that it's only we feel that we have the answers and we're coming to impose the answers on those who must be receptive at the end of what we're wanting to put down there for them. So putting control in the right hands is important. Currently, the traditional rehabilitation model focuses on provider-centered scheduling. You that offer the service, you do the scheduling. Whereas telerehab can empower people. There can be personal scheduling. They can decide when they want treatment and how it can fit into their routine. In most cases, traditional rehabilitation is in institutional settings. With telerehab, it can be in places that's familiar to those who need the rehabilitation. In the current tradition, we have limited choice in care approaches, but with Telerehab, we could customize according to the needs of those who need the services. Currently, in the traditional rehabilitation, we have this dependence on caregivers and transportation. We might be able to reduce this reliance on others for basic health care. And so we are saying technology should amplify our voices and not replace them in terms of what we are wanting to do. So the core benefits I've obviously spoken about is the accessibility, the autonomy, and even affordability in terms of what needs to happen. So once we have this telerehabilitation in place, this could be the long-term outcome in terms of what we talk about. When we talk about sustainable development goals, we talk about sustainability. So it's not a quick fix. It's something that needs to last over a long period of time. And the key enablers for us to be successful is that we need to be ethical when we do this, co-creation. There need to be cultural relevance when we take this into consideration. We understand from our projects that there need to be digital literacy training, and there needs to be connectivity solutions for low resource areas in order for us to be effective in what we're wanting to achieve. My team is very good, they're showing me my time. So the challenges and the solutions in terms of connectivity, privacy, and trust, we need to engage around this. And how will we be doing it when we talk about these telerehabilitation as an option in terms of addressing mental health? So when we speak about our implementation framework and pillars for success, there are three aspects I talk about. One is the policy support, two is community engagement, and three is professional training. I was very excited when I listened to what this conference convener does in terms of your full package that you offer. And when I talk about what I'm saying here is your package can actually assist in doing all of these things, because we need to talk about policy support, we need to talk about community, and then the professional training that needs to come in terms of what we're needing to do. Everybody talks about alignment with SDGs because that is where we're going. The world is moving in that direction. 2030 is around the corner. It's 2025, 2030. 5 years to go. What have we achieved? Have we reached those goals? And so telerehabilitation as a driver for inclusive rehabilitation globally. We can address good health and well-being. We can address reduced inequalities in terms of SDG 10. And one of the main goals of the SDGs is leave no one behind. Leave no one behind. And no one left behind in mental health care remains a challenge for us. We need scalable, adaptable, and inclusive interventions across geographical areas and across cultures. 5 years? Do you think we're going to achieve it in 5 years? I don't think so. Someone is saying, let's all cross our fingers and hope we achieve it. We can only achieve it if we work together, if we raise the awareness, if we find solutions collectively, if in the room, like a World Disability and Rehabilitation Conference, there's not only health professional workers, but that we're bringing in people from other disciplines into the room to find solutions with us. So ensuring principles become practice, we need meaningful participation. That's what I'm talking about. We need an equity focus. We need privacy and dignity, and we need accountability measures in terms of what it is that we are wanting to achieve and how we are going to achieve it. It needs for us to do the research that we have spoken about and pull the information together in terms of finding sustainable solutions for everybody. So critical questions that I want us to address is, how do you ensure telerehabilitation doesn't exacerbate existing inequalities? How do you maintain clinical standards in remote delivery? What are the long-term funding and maintenance considerations that we need to think about as we talk about telerehabilitation in addressing mental health? And how do you address diverse cultural understandings of disability and mental health? We cannot leave that out. Just this morning I had a conversation with one of my colleagues, and she's here in the room, and she's an established academic, has completed her PhD, and just recently someone diagnosed her to say, you have ADHD. And her parents were like, no, that cannot be true. No, that is not real. So the denial, even at this stage, is still there. And so when we are dealing with complex issues like telerehabilitation and mental health, we need to understand the cultural background that drives where people are living in the communities and how they will accept what we are offering them in the spaces in which we are moving. And so from rights to reality, we need to mandate disabled people's participation in telehealth policy development. We need to adopt co-production models with disabled service users. We need to design with disability communities, not for them, but with them. And we need to hold systems accountable to rights-based standards. And we need to amplify disabled people's voices in telehealth discussions. And we are able to do that in the spaces in which we move. In conclusion, telerehabilitation is a powerful catalyst for inclusive rehabilitation. It does have the potential to transform mental health services worldwide. It is a technology that can be used as a bridge to dignity, equity, support, and inclusion. And it can be a supportive innovation for policy integration and investment. But it starts with us. And we need to be the ones who advocate for this and drive this in a way that makes it effective in the lives where it needs to be done. I think that's my last slide. Thank you.